Most of you are here at this seminar because you have been offered a wind power oxygen concentrator analyzer for your region of Tanzania. Now, the oxygen source, typically in a respiratory distress, will be an O2 cylinder, but in some cases it may be directly an oxygen concentrator and a nasal cannula if the patient is able to breathe on their own. If they cannot breathe on their own, inhale or exhale, the oxygen source will go into a ventilator, and the ventilator will feed an endotracheal tube in the patient. So tomorrow we're going to have an in-depth discussion of oxygen concentrator, theory of operation, service, and calibration. So at this point we're just going to describe the overall operation, which involves twin sieve beds. These sieve beds basically trap nitrogen as air is forced by a compressor through alternately the two sieve beds. Oxygen is passed because it's a smaller molecule and the nitrogen is trapped. Now at some point the sieve bed will become saturated with nitrogen, and a solenoid valve will switch the sieve beds to the one which is not saturated, and the one which is saturated will have the nitrogen exhausted and cleared. That's the reason for the two sieve beds, and generally there will be a third tank, which is a collection tank, to allow a continuous supply of oxygen to the patient. It's important to realize that the sieve beds cannot remove all elements of air. In particular, argon is about 1% of atmospheric air, and it does get passed through along with the oxygen, which is the reason that an oxygen concentrator can never produce more than about 96% oxygen. The rest is mostly argon and some trace gases. Welcome to an island of peace on my stormy little planet of colors. So an oxygen concentrator is often not used when oxygen is critical to the survival of the patient because loss of power can cause the loss of the oxygen source. And we know that can be a chronic problem in Tanzania. However, there are also stations which allow the oxygen concentrator to pressurize and fill an O2 tank. This can even be done at home for home use, and the tank is certainly a much more reliable source of oxygen, at least until it's exhausted. The alternative to what we call pressure swing absorption oxygen concentrators is oxygen distillation plants, which are usually cryogenic and produce liquid oxygen. So large hospitals may have these distillation plants, or they may be done industrially, and a hospital may order liquid oxygen delivered in tank form. But the basic idea here is distillation is a much more expensive and critical process, and the oxygen concentrator can produce a low-cost source of oxygen, which is just as effective. I'm quite proud of the detail. General Trelane, retired, sir. So when we talk about low-cost, effective alternatives to oxygen distillation, oxygen concentrators are not limited to small portable units. There are industrial-sized ones which operate on the same principle that can supply an entire hospital oxygen needs. And they also are used to create pressurized tanks of oxygen. So in the event of electrical power failures. Oh, I wouldn't hear of it. You shall join me in a repast. I want to learn all about your feelings. Oxygen concentrators are appropriate for critical care applications. However, they are FDA Class 2 devices, not Class 3. Class 3 are devices where, if they fail, a patient's death is imminent. So the assumption with an oxygen concentrator is that there is backup sources of oxygen, and if they do fail, the patient won't die immediately. So because they are Class 2, they are not rigorously regulated by FDA agencies, and that puts limits in terms of where you would want to use them. Now, bottled oxygen should always be immediately available as a backup O2 source in case there is a failure of the oxygen concentrator, and that failure of O2 source could threaten the life of a patient. Technicians and biomedical engineers, we do have to treat oxygen concentrators as though they are a critical source of patient oxygen, which means that we have to maintain regular service and also calibrate the output to make sure that they are delivering adequate oxygen levels. Now, an average zeolite container design will often produce over 20,000 hours of operation before needing replacement. However, in places where there is excessive humidity, the lifetime can be adversely affected, and in some cases, if the moisture actually enters the zeolite canisters, it can cause the zeolite sieves to swell and actually close the airflow, and that's diagnosed by seeing high pressure at the input to the canisters. So it can take up to 20 minutes of warm-up time to reach the peak oxygen saturation. So it's important when calibrating the units to wait an adequate length of time after turning on the concentrator. The faults that you can see include hose leaks, compressor and valve leaks, O2 sensor aging, because many of these do have O2 sensors integrated that will, for instance, turn off the unit ready light if the oxygen level drops too low. However, most oxygen sensors do have a lifetime, so that can be necessary to check.